Okay, thank you very much. And I must thank this very important CHIP program for giving me this nice opportunity. And I am, excuse me, so that I could not join you there, but certainly I'm very happy to be here. And thanks, Deepak, and your team for this wonderful program I was hearing in the previous session. So now I'm going to share with you some of one live case and which we have recorded for you, and also start with my presentation first.
Milu?
So can you see my presentation? Yeah.
Yes, very much.
Milu?
Okay. So basically, I'm also going to share with you, protected PCI.
Timing mode होगा.
I think there is some disturbance coming from Dr. Panja's, so somebody has to mute. Okay, so basically what I'm going to discuss with you is more of a protected PCI situation, and this is the clinical evidence pathway as to how we started doing all this and where have we reached today. So you can see that we started with some registries showing the efficacy, the safety of this option, and then of course validation was done with the studies, and one of the important studies was the Protect 2, which was a randomized trial, and the Protect 3 was the post-approval study of 1,000 patients. And now the Protect 4 is going on right now, again to establish the high-risk PCI procedures with MPELA support versus without MPELA support. So that is the situation right now, and this is how we have progressed. From 18, I think we started doing our MPELA cases, the routine MPELA cases, apart from the ones which we did 10, 15 years back. Now we have this trajectory, and now the more and more cases are being done, as you can see. And the survival rates have also improved a lot with the average baseline EF, which initially it was like 40-45%, and now it is in the range of 29%, which is also, like you can see here, this is the comparison with the average EF in United States, which is the orange line, and the yellow line is our line, where we all started coming to about average of 29%. So these are the complexities which we can handle now with either a complex coronary artery disease, hemodynamic compromise, or patient comorbidities all coming together. And based on this, we started using, this is one of the guidelines, and now we have the Indian guideline also just recently published. So these are rough estimates as to how and when we should use these MCS support. And many of these algorithms exist, but more or less they are on the same platform. And this is the consensus and the clinical society guidelines which have developed over the years, starting from cardiogenic shock to a protected PCI situation. So with this, I think I'll move on to the live case straight away. And this is the live case I'm going to share with you. And here it is. How do I share? Okay, share screen. Okay. And right. Okay.
Medanta Heart Institute in Gurugram. We are in the cath lab, and we are now ready to do a complex coronary case. And along with me is Dr. Nagin Chauhan and Dr. Abhinav. And also we have a guest here today, Dr. Federico Pappalardo from Italy. He is a specialist in advanced mechanical circulatory support, usage of these devices, and also treating very complex hemodynamically unstable cases. We will first introduce this case to you.
So he is the 83-year-old male. He had 3 angioplasties in past, and they were done for LED and for TURP. The proximal LED stent has some restenosis, but this time he presented with acute LVF, stabilized, TOPS were positive. Echo then showed ejection fraction of 30% with achronesia of anterior valve, mid-distal part, and rest of the part hypokinetic. We have done a PET scan also which showed 25% hibernation with no infarct. So this is the angiogram. You can see that the distal left main is tight and the circumflex ostium is actually very tight. And LED ostium has not that much disease, but this is the left main, and this is the circ ostium, very tight at the ostium, and diffuse disease in the left main, which is also very hazy. So the plan is to do a left main bifurcation angioplasty from the proximal part only. Considering his age, we are not going to touch the distal arteries. We have done a PA line also, and PA pressures are 40/11 right now.
You can
And systemic pressures
is okay.
are also stable around 150 to 170. So this is the case, and this is the plan.
So you, as you already saw on the angiogram, that this is a treatment for the left main bifurcation. There is a stent in the circumflex coming to the proximal circ, and there is a stent in the lady which is also coming to the proximal part more or less. Currently, we are going to address this left main bifurcation, which also appears to be fibrocalcific lesion. Before we go ahead with that, we have planned to put a mechanical circulatory support, and for that, what we have done is, this is RCA, which is very small. So here you can see that we have taken a contralateral injections to identify the artery size and also the bifurcation. This is very, very important. You can see that now to determine where we are going to puncture, because this is a 13-inch device, and we have to put a proglide here so that we have a pre-close. So we have put two proglides. This is now a 11-inch sheet which we have already put. This is an Impella 2.5 for protected PCI. We generally use a 2.5 liter pump. However, 3.5 can also be utilized. So we have this wire which comes with the system, and now I'm putting this wire so that we are able to put the sheet. So we have the sheet now. We can have the sheet ready. So this is the Impella sheet, which is 13-inch, and the CP goes in a 14-inch. So this is a 13, which takes, the 2.5 liter pump quite easily.
Sir, what about the groin access? Is it ultrasound guided or fluoro guided always?
Okay, so the groin access is, you can do either way. So we do it, both ways. We check with the ultrasound, which is always there in the cath lab, especially for these high bore procedures. And then as you saw, we did the micropuncture, took a shot, and then we went from the other side, because that also gives an idea about the tortuosity and also any disease, and calcifications in the path of this Impella catheter. So these are the two things, the precautionary things which we do before we put the Impella inside.
Move the whole of this introducer and wire. So we are flushing it. Okay. And now the heparin has already been given, so there is no problem, and we will maintain the ACT at around 250 plus. So now you can see that the Impella catheter has been opened up, and you can see now that the part of the catheter which is now going to the console, Ishwar is loading it on the system. Okay. So all the instructions are coming in. So what are the precautions which we have to take, Dr. Paplardo, for initiating this Impella, and what are the problems which can happen?
So thanks for the invitation, and I'm happy to join this meeting. So I think it's very important to take advantage of the console, because the procedure is self-driven. So it's very easy to start the priming system. The point comes to the issue of the time required, especially when you are doing this implantation in emergency case in patients who are in calcitonic shock. And I think it's very important that the team is aligned, that someone is looking at the access and someone else meanwhile can prepare the pump, so that you can optimize the time for pump preparation, and it can take very, very few minutes, as long as the access is secured by the primary operator.
Okay. So here we have the pump ready, everything is okay. And this is very important, this red tube, because through which the wire will come out to the right hole. So now we are ready with the sheet. We are going to put a wire which comes with this and on a picture. So let's have a picture, please. Because picture will facilitate the passage of wire inside the ventricle, and then this catheter will go on the inside the ventricle. Okay, going. Okay. So now you can see on the fluoro image that we are.
So we understand that this catheter is 9 French and the area where you have the pump is 13, 14 French, right?
Yes, yes, absolutely.
The tail has gone in, as you can see. And now we'll take the O18 wire, which is the wire which has to be taken for passage of the impella catheter. So we will shape the wire. This wire, O18 wire, has been shaped according to a picture. Yeah. Now I will try to push it inside. So here I am with the picture. So the wire is inside and in good position to take the catheter inside. So now the wire is inside and in good position. So now you can see here that there is a small red tip through which the wire will go inside. This is the O18 wire, and we have to be careful that this does not go out. Okay? Because sometimes it gets pushed out and then you will lose the position. Okay? So now we are okay. This can be taken out. At times inadvertently the whole thing gets pushed out. He is holding the wire and I am now taking the catheter inside and okay. The catheter is in position. So the most important thing now is the right positioning of this catheter so that it is stable. It should not be too deep, it should not be too high. So Dr. Pappalardo will give us some comments on how to keep in check on the console whether we are in the right position or not.
So there are multiple options to double check whether the pump is sitting in the right position. First of all, you have to look at the position signal in the console. So here the pressure monitoring is clearly showing an aortic tracing. So that means that the pump is adequately above the aortic valve. I think that also fluoroscopy is informative because you see that now the pump is sitting very well across the aortic valve, and you see that the pigtail is fully deployed, so we have no kinking, no bending of the device. So currently I think we are absolutely in the right position, and we can we can start the pump.
So the pump is started already. You can see the console. And can you tell us something about the motor current?
Yeah, so whichever continuous flow pump with is implanted across 2 chambers, the pump flow will be calculated according to the current consumption. And the current consumption changes over the pump head according to the cardiac cycle phase and of course the residual function. So here you see a correct fluctuation of motor current consumption during systole and diastole. And of course, the pump is more efficient during diastole, so the motor current is lower. And you see that during systole, the consumption of the pump is increased. So I think that at the end, we can be safely sure that the position is fine. Lastly, ECG is always useful because if there is any mechanical interaction with the left ventricle, you will see PVCs, which is not the case. And I would remind you that in this patient, we also have the opportunity to monitor the pulmonary artery pressure, and you see that diastolic pressure is progressively reduced. And that means that the pump is unloading the ventricle and there is no interaction with the mitral valve apparatus. So I think we are on the safe side.
So you have a PA catheter there. The PA pressures started coming down once the impella started working.
Pull another record. One more
Praveen,
one.
sir, can you
Yeah,
hear
yeah.
me?
So you-
Sorry, yeah. Tell me. Yeah.
We could see a PA catheter there. Did the PA pressures
Yes.
come down with the once the impella
Yes.
started working?
Yes, so that is what Dr. Papalardo also commented, that the PA pressures have come down and the patient is very stable. And PA catheter is actually a very good device. I generally use it in all these complex cases. Earlier, many years back, at some point in time in very complex cases, it was being used, but then everybody stopped using it. But now, since we are again doing more chip cases and with all these devices, so we get a fair idea as to how the hemodynamics is changing.
So we see that it's a multi-purpose catheter. Is it a multi-purpose catheter
Yes.
or routine, or do you
Yes.
have a Swan guns?
Yeah, the Swan gans we use in those patients who have to be subsequently monitored in the like cardiogenic shock patients and extremely hemodynamically unstable patients who come from the CCU with the Swan gans. But mostly, if we have to just do it in the cath lab itself, we continue with this, and then in case we want to continue that, then through the neckline, our anesthesia team will put the Swan gans catheter so that it can be followed up into the
Also why,
CCU.
because this is a calcified lesion, and sometimes if we have to take the open NC balloons, then it is not a problem even if we have to go to high pressures. So the pump is in good position, right?
Yeah.
And the PA diastolic pressures have come down quite dramatically. So that means it is unloading now. Yeah.
We started with 42 and 15.
So second wire is in the lady now.
So do you feel that once the
Oh,
impella is in
I
place, straight
was
away go ahead with PTCA,
thinking-
or you need to wait for some time so that the hemodynamics little improve and then start the procedure?
Yeah, so in this patient, yes, it's a good question. In this patient, actually, the baseline hemodynamics is not so bad, and everything was looking okay. This is a predominantly protected PCI, but those patients who are in cardiogenic shock or who are in a extreme hemodynamic situation, it may be worthwhile to just stabilize these patients, or sometimes even just continue impella for a few hours and then have some more stabilization. And then only you can do the procedure. So that's another very good thought and option.
Praveen sir, what is the current pharmacological support for the patient now, or?
Nothing, because as I said, this is a predominantly protected PCI. This patient was not in cardiogenic shock.
So Dr. Sharath is also here with us from Hyderabad. Sharath, what way would you have different thoughts on this?
Yeah. See, Dr. Praveen, so I have one question. See, what is a rise in mean pressure which you see once you start, impella, and generally how much time it takes? Because often I see at least there will be a 20 millimeters of mercury change in mean arterial pressure in these patients, but it takes at least 10 minutes to see that map change. And what is your observation, sir, in your experience?
Yeah. So, as I said, that this patient from the baseline had as a good map, there was no problem. And those patients who are borderline, like, who are extremely borderline, who are hypertensive, in these patients, certainly, we wait for a while, as I said, and sometimes it can even take a little while, So to, have the hemodynamic response, and then it is better to just wait. These patients are many times ventilated. So we have to take that into consideration, definitely, for sure. And just putting the impella straight away and doing the procedure is not the best thing to do in those kind of cases. But in a situation like this, especially, so we have now two groups. So we have to, concentrate that when we are using it in a protected PCI situation or when we are using it in a cardiogenic shock type of situation, the approach is slightly different. Okay.
So with the impella, whether there is any difference in ACT level, how to give heparin, any different target level or nothing?
Yeah, so the ACT level, as I said, should be somewhere in the range of 250 to 300. And so we, keep checking the ACT, and at the outset also you have to check the ACT. And sometimes, the heparin, but if it is a short procedure, typically about 10 to 15,000 is good enough. But if it is a long procedure, then you have to supplement at every 20, 25 minutes interval. Okay?
Yeah. This looks okay here. And now this is the unstented portion, which is looking okay. There is some calcium plate on the 9 to 12 o'clock position. And then, of course, it doesn't look very tight here. Reasonable. The plate size is increasing, which is like almost 180-degree plate. And now we are coming into the left main. Okay. And here you can see that in the left main, the calcium is quite predominant over here. And going up to, this is the size of the vessel here, the left main. It is quite good. So the LAD doesn't appear to be tight at the ostium, but there is a significant plaque over there and the calcium. So you can see that the lumen is how much at the ostium. It doesn't look so small. Area is still okay, 6.7. It's 4.7. So certainly this is small for a left main. So now I am in the circumflex. Again, you see the stent is okay. And we are pulling back. And, yeah, here. You can see that the disease is here at the ostium of the circumflex. And now I'm the left main. Okay. So this is the ostium of the left main, the circumflex. So it is predominantly in the distal left main, the lesion which is there. So what is the size of the proximal circumflex? 3.5. So we can take a open NC 3.5. So now the question is whether we should do a dedicated tube stent or a provisional. That is what we will see. So
we could understand that I was the least dimension showed us 4.7 left main.
Yes.
So if it comes to around 6, would you have deferred this procedure?
I mean, generally it is because it's having a 6 is very, very uncommon. And in fact, even if it is 6, so we will end the stent in that area where, because we have the stent, the biggest size of the stent is 5, or the stent which is, so we have to choose a stent which can go up to 5.5. And there are stents now which have the capacity moving from 3.5 to 5.5. So that is why the stent selection is important in these cases. So we took this is the 3.5, I think 12.
Go up. 1, 2, 3, 4.
From left main to
5, 6, 7, 8.
circumflex.
9, 10. 12. So the balloon has slipped back, deflated because of that calcium plate over there. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 14, 16, 18, 20. Deflate.
So this is a 3.5, I think 3.5 into 10 millimeters cutting balloon. So we did cutting balloon here, going up to very high pressures.
The inflation, blood pressure decreased by about 50 millimeters of mercury, but it was maintained overall.
So we are taking a 3.5, same balloon for the main to LED part, so that if there is any issue with the calcium plates, it will be taken care of. So there is some intertwining here. It's okay. It's okay. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 14, 16, 18, 20. 22. Deflate. We have done these two
You can see the
palpations.
pressure is recovered. As soon as we are dilating, pulse pressure is going down. As soon as we deflate, again pressure normalizes. But patient otherwise is maintaining very well with the support.
So while using this cutting balloon, in the past we used to say that we need to inflate it very slowly, deflate it very slowly. Would you say that gone are those days and we would go up fast and come down?
I mean, those are ways of handling these kind of situations, but certainly here, since the size of the vessel is quite big and we wanted to really go high pressure, so we went quickly. Otherwise, many times, as you said, yeah, we do that
Already
as well.
open, and then there is no problem in crossing it. Okay. Left main to circumflex stent. 3.5, 15.
So you can see that the dilatation is quite adequate.
I think we are okay. So this is stent is looking a little small because it is not touching the. Also, let us do this thing. Cine boost. Go do a cine boost. Also, it is touching it. It's okay.
It is not coming to okay.
It is touching. Check please.
Not coming to okay.
Okay. Give me 18.
18.
18 should be fine. So we have taken as 3.5, 18 now. So you see the PA pressures. PA pressures are rising and deflate. So this looks okay. LED is maintained. I think it's okay. But the PA pressures are high.
Yeah, but I think we should discuss about treating blood pressure because this patient is now very hypertensive.
So it is mainly because he's training a lot.
Yeah.
So we can wait for some time. Some nitro.
Listen.
Now the PA pressures are coming down, you see? The PA pressures have now come down to 40 again, and systemic pressures are also coming down. And the motor current is also improving. On the green signals you can see. The plateau is going down. Okay? Yes. So now we'll have the balloon for the pot. So here we are taking a post dilatation balloon, which is a 4, but we will go with a 5 also.
Focus up.
Okay, so we'll start from here. Go up 1, 2, 3, 4, 7, 8, 9. Deflate. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12. Okay, deflate. So I'm now doing a pot with 5, 10. The PA pressures are now 29 by 11. So see how the hemodynamics is changing. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Deflate. We are fine. I think this is quite a lot. That looks nice. In fact, it looks very good.
So we have validated LED, so we have to do it, otherwise it is looking good.
LED is looking very good. The left main is opened up very well. Everything looks good. So I'll take out the wire, the LED wire. We can use same wire because we know where we have to go. So I'm trying to take this wire out, okay, which is not difficult at all.
Sir, are you working from both the groins or is it single axis technique?
Yeah, in this patient, it is, we are working from both the groins, but, our predominant strategy these days is to do with a single axis technique.
Because I have to fit a little bit more snugly into the left main. Okay. So now I will try and position it.
midpoint of the implant.
So we entered into the LED without much difficulty. Okay, we are through the good stretch.
Cranial.
Okay, epicranial. So the LED wire is in reasonable position now. So we'll have to make some passage in here. Give me a 2.5 balloon. Yeah, 2.5.
One 2.5 and one 3.5.
So it is crossed quite easily. So everything seems to be okay as of now. So this is going through the 3.518 alpine stent. So there we are, okay. So we can do the dilatation now on 2.5. Yeah, go up. 2, 4, 6, 8, 10, 12, 14, 16, deflate. So now 2 each, 2 each, 4 each, 6 each, 8 each, deflate each. So this creates the bed for the next stent to be brought in. And I'm taking this out and take the stent in. Okay, let's have the stent, please. 3.5, 3.515. It processed quite easily. And since it is a tap now, so I will go move as distally as possible and see on the cine images, we should have minimal tap. So a little bit inside should be fine. And in this view, I think the tap is quite nice actually. If it stays there, if it doesn't move, it will be the best tap. Because I am trying to do a micro tap. Yeah. Okay, go up. Stent go up. 1, 2, 3, 4. Take one. 1, 2, 3, 4, 5, 6. So you saw that there was a lesion, the proximal LED lesion is now given way. It's nice. How much is that? 6, 7, 8, 9, 10. Deflate. Yeah. So the stent is looking, the pressures are going down a little bit, but the console is telling us that the mean pressure are still 110, which is good. Okay. So now we are ready for the kissing balloon inflation. Both these balloons. Okay. Yeah. Okay. 1 each, 2 each, 3 each.
Can you show the pressures also?
6 each, 8 each.
Yeah, what was the question?
Can we see the pressures? They are seen, not seen in our monitor.
Oh, okay.
10 each.
We will see that
With
just
that
now.
each. So that's looking nice. Well, one by one, both the balloons will be out. Give some nitro, please. So now we can do a final part doing a 5 balloon. This looks quite nice. This looks okay to me. Okay, let's look at the Cine Boost. Looks okay. Yeah. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9. Deflate. Okay. Fine. So, Dr. Paplardo? Yeah. So, will we take out the impera here itself? Yeah. Yeah, definitely, yes. So, here you can see that the ostium of the circ is very nice now, rounded and lovely. And the left main is also looking very good. And the stent is fully opposed and dilated. Okay? Yeah, so we are fine. Everything seems to be okay. And I think I'll stop here. Yeah? Patient is stable, everything is fine. And we are done. Thank you very much. And now we are going to take out the impella catheter, which I would like to show you very quickly. How do we take it out? First, the guiding will come out. So the guiding goes out. Bring the table down. The table down. Okay. So he has to now lower the flows.
Turn down the pump flow.
Turn down the pump flow. Show the pump. Show the pump. Yeah. Yeah. So now it is how much? P8.
Yes, 8.
P. Okay. Okay.
So now you have to reduce the pump speed.
Reducing the pump speed.
Down to P2.
Okay. So we are ready. Okay. I'll take it out from the LV into the aorta first.
Fluoro, please.
Fluoro, and here
Fluoro.
I am. Okay.
Yeah.
So I am in the aorta. So we can switch off the pump now. Okay. Pump switched off. So I'm taking it. So show my hand now.
Yeah.
Sometimes it gets stuck.
Can you put the fluoro image?
Show me the fluoro image.
Fluoro.
Fluoro,
Can you
please.
put the fluoro down?
It's okay. I think it is stuck in the sheet. So we'll take it out. Pull it back. Pull the
Everything
cable out.
You can take everything out.
Yeah.
Dr. Praveen, I'm Dr. Sharath here.
That's
So,
only it's okay.
can you please explain something about, when to wean off on table in these patients, and what are the few parameters, which we have to see before you pull off your impella on table?
Yeah. Okay. So basically, this is a very good point and a question that when to wean out impella. So mainly weaning as such is a process which we mainly are concerned in patients who are, hemodynamically unstable patients, cardiogenic shock patients, where we have to really bring them out to the ICU on an impella, and then keep checking the pressures, keep checking the urine output and other hemodynamic parameters like wedge pressure, and then make our decision as to about the weaning process. And in this kind of a situation in protected PCI, I would just like to simply tell everybody that once the procedure is done and everything is done, it is most reasonable to take out the impella in the cath lab itself because of two reasons. One, in many times the cath lab the ICU staff is not so well trained to take care of the impella positioning and many other things. And then subsequently also you have to do the closure. So the closure also becomes a little bit messy when you do it in the ICU. So doing this in the cath lab, if the PA pressures are stable, patient is fine, and the blood pressures are okay, it is okay to just remove it. And that's what we typically do in the cath lab, because the other thing we can do is you can check it from the other side also, that whether it is
It's okay. It's all.
the site is okay or not.
Now we can put a small
But do you
wire here
always
and just close.
wait
So
for
we'll
some
close it,
time
you-
after
you
coming
close it.
down on your pump flow to P2 to measure
Yes.
your pulmonary artery hemodynamics? That
Yes.
makes sense, because
Yes.
at times, one of my case, after 15 minutes of coming to P2, his PCWP and PA pressures, everything has gone up. Then I have to go back to its normal flow and continue pump for next 2 hours. I think that is something which is very important.
Absolutely.
Yeah.
Absolutely correct. That we have to grade our patient and also optimize as to when and how to remove this. So that's a very important
Because
point.
the
you
PA
raised.
capture also, because PA is now 28 by 10.
For how long would you monitor the PA pressure in ICU?
I mean, again, if the patient is, as far as these kind of patients are concerned, you don't even need to monitor, because as I said, his PA pressure is now 28, and he is absolutely stable. the patient is not in failure, saturations are good, all the parameters are biochemical and hemodynamics are okay, so that's fine. But in those cases where there is a issue, either of these parameters, then certainly we'll have to follow them up in the ICU, and then even keep the PA pressure, the SWAN GANs, because SWAN is a very important thing in those kind of patients.
As long as your impella is on, you have to continue.
So do you feel aortic regurgitation,
So,
any amount of aortic regurgitation will be a problem?
Excuse me,
Do you feel aortic regurgitation can be a problem?
excuse me?
Aortic regurgitation.
I mean, aortic regurgitation, yeah. As such, aortic regurgitation is not a problem because it is not like, IBP where, we are actually increasing the diastolic pressures. Here, what we are doing, it is a continuous flow pump. So it is not in the systole or diastole, so it is okay.
In the second knot,
For how long you can retain the pump, sir?
I
Maximum?
will compress for a little while. It's not as much.
How long you can?
Keep the pump if necessary.
Yeah, I mean, you can keep the pump, I don't know the longest time, but you can certainly keep it for a few days till you have the outcomes, or you have start developing complications like hemolysis or limb ischemia, etc. But as I said, to keep the pump inside, we don't need to keep the 13 French sheath inside. There is a sheath, this sheath can be peeled off, and then you can insert there is a sheath on this, so which can be reinserted, which is a 9 French sheath. So then the ischemia doesn't happen that much.
Not going too deep. Maybe it is stuck somewhere in the middle.
So this is the ProGlide we are using, and sometimes the ProGlide stitch can,
It is almost
hold
closed.
it with some
Now you
tissue.
can cut it and see how it goes. After cutting, since the wire is there, we still have some access. Yeah.
Dr. Praveen, can you comment on
Yes, I
your
think you are done.
experience
Thank you very much.
or the data on the risk of aortic complications, stroke complications with impella? Your experience also valuable.
Yeah, so I mean, in our experience, we didn't have any aortic issues or any complications in the arch of aorta or injury to any part, but certainly vascular complications can happen, and these could be bleeding, these could be like hematomas, or so all this has to be taken care of very seriously, because vascular complications are also with high bore access systems. This is something which is very, very important. And bleeding can also happen. Hemolysis has to be checked. All those things have to be considered while you are using these kind of devices.
And we'll have some discussion if you have
So
any
even
questions.
pre-closure device can be used in patients where you are continuing impella for 12 hours. Now, most of the operators are preferring pre-closure, even patients where we are going to continue. But the only challenge is we have to make sure the sterility of the entire area. That is something which we have to be very conscious about. And next thing is, if by chance pre-closure is not working, now the new sheath has a side port, so through which you can put a wire inside. So that will save your bleeding. So you can send a wire before you pull out impella. So even if the pre-closure device didn't work, then you have a wire inside, which will save. You can do things, subsequently. Yeah.
So how will you compare an impella against IABP in your experience?
So you are asking me, or hello?
Sir, yourself, sir.
Yeah. So you are asking about the comparison of impella versus IBP. I mean, for IBP, now we have that so much of evidence that IBP has not been helping us through, cardiogenic shock studies, through the PROTECT-2 study. So if we base on our, evidences, then certainly IBP has not shown much benefit. But as far as the experience goes, many of us in India are prompted to use that because of two reasons. One is our own experience, and the second is the cost. The cost of IBP is so, patient friendly that many times we are, kind of forced to do that. Yeah, because if a patient cannot afford Impella, or the hospital cannot afford Impella for that patient, then the only option left is either we do nothing or we use IBP. And IBP is the best part of IBP. I mean, is that it is so simple to use, and the chance of having a complication is much lesser. It's a 7-trench device.
But the confidence it gives to the operator and the team in a complex case, I feel is much high compared to ABP.
Yes, yes.
So thank you for that wonderful
Thank
case
you.
and enlightening
Thank
us
you very
on
much.
the Impella device. Very thanks to you.
Thank you very
sir.
much.
Thank you for the nice case and nice discussion,
Okay,
sir. Thank
bye.
you.